Hello everyone, Leslie Cornwell here, Midwifery Business Consultation. This online course is about non-reassuring fetal heart tones and the SBAR communication method. What is a fetal heart rate and why is it important? A fetal heart rate is a monitoring concept to be able to check on how the baby is doing. We can ask the mom, are you having any concerns, questions, issues, pain, discomfort? But we can't ask the baby. We have very limited ways to find out how the baby's doing. Reassuring signs are fetal movement, but the heart rate is really the best indicator of good oxygenation we have of the baby. Is it skipping beats? Is it low? Is it high? Is it dipping during a contraction? Tells us different things if the heart rate's dipping after a contraction. So understanding how to do intermittent fetal monitoring and to do continuous fetal monitoring is really important as a midwife. Non-stress tests versus during labor. What are we looking for? Why? So fetal heart rate monitoring, you can do it with a fetoscope after 20 weeks gestation. It's harder to do. You can do it with a Doppler intermittent monitoring, or in the hospital, they'll use external fetal monitoring for a non-stress test or during labor. You can also do internal fetal monitoring in the hospital with a little scalp electrode that goes on the baby's head. So there's many different ways to keep an eye on how the baby is doing, and the goal is to give us information and help determine reassurance, or we should do an intervention to help the baby right now. So fetal heart rate, it goes constant and minute adjustments in response to the baby's environment. So if the baby has got good fluid around it, the cord's not getting kinked, that the baby's been well oxygenated, good nutrition, no risk factors during pregnancy and labor, we wouldn't expect that the heart rate would go down. Intermittent fetal monitoring is using the Doppler, typically in out-of-hospital setting for low-risk healthy women per A1 guidelines, and we'll talk about that a little bit further. Continual fetal monitoring is pretty common practice in the hospital setting. It can be external or internal, recommended for high-risk women, even though most of the women in the hospital setting are having continuous fetal monitoring being done. Continuous fetal monitoring, there's 3 patterns and categories based on the newest guidelines for interpreting a monitor strip. Category 1 is typically reassuring. Category 2 is ominous, meaning that it could be good or bad, we just aren't quite sure. Category 3 is typically reassuring, the baby is showing us signs that oxygen is of concern. Reassuring category 1 typically has accelerations present, moderate variability. There's usually not decelerations. The heart rate's in the normal range, 110 to 160. Non-reassuring category 3 fetal heart rate typically has decelerations, especially late decelerations are very concerning. Those are decelerations that dip after the contraction occurs. And you'll figure out once we're monitoring intermittently, we're trying to get that point in time to say, is this when the baby's getting good oxygen, not getting good oxygen? Those late decelerations after contractions are what we're trying to hear when we do intermittent monitoring. And then non-reassuring heart tones can either be above 160 tachycardia or below 110 bradycardia. So what is intermittent auscultation? It is when a care provider listens to the baby every once in a while, usually active labor. The recommendations are to do every 30 minutes. And then once the mom is pushing, not when the cervix is complete, but actually pushing, it's 5 to 15 minutes apart. And we're listening for about 60 seconds. You want to be able to hear during and after contraction. Your goal is to get what's on that continuous monitoring strip. If there's any signs of late decelerations or any signs of stress to the baby. Unfortunately, only 3% of our women during labor are getting this model of monitoring, even though it's recommended to be used for all low-risk healthy women. So it's one of those examples of intervention leads to interventions, that by continuous monitoring low-risk women, we actually are increasing our complications. So fetal heart rate tones, normal is 110 to 160. Bradycardia, low heart rate is less than 110. 100 to 120 with no other signs of concerns. Typically, most providers will just watch it and note that the bradycardia happen below 110. Possible causes of bradycardia can be the mom's sugar being low, there's some sort of oxygen concerns with the baby, fetal compromise, cords being kinked somewhere. So sometimes in the hospital they'll do an amnio infusion to help get some fluid around the baby, especially when the water is broken. That's a nice option to see if it's the cord. Sometimes it's baby's position. If there's a narrowed pelvis and the baby is asynclitic, a little cockeyed, a little bit posterior, it's the baby gets stressed out from trying to fit through a hole that they may or may not be able to fit through. So that can cause stress. Placenta, if it's an older placenta, if it's a placenta where there was an abruption, a partial abruption in the past and it's not working as well, the placenta is the baby's lifeline. So if there's little signs of stress and baby's not getting good oxygen through the cord, that might be part of it. Tachycardia is the presence of good variability most of the time. Sometimes as it gets higher and higher, more like 180, 190, 200, you start losing that variability. It becomes minimal to absent. So tachycardia can be caused by mom having a fever. I've seen it with epidurals. I've seen it with dehydration, certain medications, anemias, hypoxia, the baby not getting good oxygen, infections, and the fluid, the amniotis. Sometimes an arrhythmia of the baby. So having a heart rate that's fast is just as much of an emergency concern as when the baby's heart rate is low. The baby is telling us they're stressed out and we need to be doing some interventions to help the baby. So what to do if you have non-reassuring heart tones? It makes a big difference whether you're in the out-of-hospital setting, home birth, birth center practice versus a hospital, because your interventions are going to be different. Either way, you want to stay calm. You want to clearly communicate with the mother and her family what's going on. Many of these interventions, recommendations can work for any setting. Repositioning the mother is usually the first thing I do, because if the cord's getting kinked, that's a simple way to reposition the baby. Sometimes the mom can get a little bit of lightheadedness. She's breathing too fast, not getting good oxygen to her and the baby. Her fingers will sometimes get tingly. You can apply oxygen if you're in the hospital setting. I usually encourage slow, deep cleansing breaths to help her and her baby. I reinforce your baby needs you to breathe just like you need to breathe. IV fluids are typically in a hospital setting. If the mom is dehydrated, that can sometimes stress the baby out. Perform a vaginal exam in any of your settings. If the water just broke, it's nice to get heart tones and make sure that there's no cord being kinked or prolapse concerns. A vaginal exam will give you a lot of information. If she was 3 centimeters and now the baby's getting stressed out and she's 7 centimeters 10 minutes later, that tells you that there's imminent delivery, and that could be the reason that the heart tones are a little low. So then you need to prep for delivery, especially if she's had fast deliveries before. Looking at, did the water just break? What color is the water? Is it clear? Is it thin meconium, thick meconium? Is there any vaginal bleeding? Is it old blood? Is it new blood? Is she having any pain anywhere? What's the contraction pattern look like? If she's a VBAC and she's starting to get uterine pain and baby's getting stressed out, you start worrying about a uterine rupture over that scar line. So there's a lot of things to think about when you're a midwife and use your assessment skills. So with the vaginal bleeding, you want to know, is it from the cervix? Is it from the cord? Is it from the placenta? Is it from the vagina? Where is she bleeding from? Where is this source? Especially if it's bright red blood, you always worry about the placenta with a stressed out baby. So there's a lot to think about with heart tones. If you try all your different interventions and it's not helping, and especially in a home birth center setting, you want to call EMS and get transport to the local hospital and give them report. If you're in the hospital setting, you want to be getting your physician involved. Once you've started doing these interventions and the heart rate is not improving in the next 30 to 60 seconds with your interventions, definitely get the physician involved, because you may have to do an assisted delivery or a cesarean section. So an SBAR is really important because it's a nursing communication tool that you can use in any situation. EMS use it, midwives to physicians, nurses to midwives, nurses to physicians, department, transferring of care. It gives you a short and concise version of what's going on with a patient so that we don't have a breakdown in communication and a mistake occurs. So SBAR is situation, background, assessment, and recommendations. So situation has to do with what's the history, how many babies has she had, how far along is she in labor, how many weeks along. We make the assumption all the time that there's one baby in there. Once in a while there's two. So any risk factors with the pregnancy, what time did labor start, did her water break, does she have any vital sign concerns, why are you calling with this, and the background goes more into those details, but the situation, why are you calling that person? We have a history of non-reassuring heart tones, this is 911, we'd like an ambulance to transfer to the hospital. Or the doctor comes into the room, you hit your call light, hey, Dr. So-and-so, this is my patient. She is a G3P2, 39 weeks, came in spontaneous labor, water broke, clear fluid 2 hours ago, GBS negative. She's having heart tone concerns, and we've tried repositioning, we've tried fluid, we've tried oxygen. Her last vaginal exam 3 minutes ago was 7 centimeters. So just telling what's going on in a short amount of time. So then the assessment we talked about, and what you would recommend. I would recommend that we prep for an assisted delivery. I'd recommend that we talk to the mom about a C-section right now, because the baby's heart rate is not coming back up and we need to deliver soon. So it is important to have confidence in your recommendations, and then the provider that you're speaking with can make their own decisions, but it's really important to know the situation, tell a good background history of what's going on, your personal assessment of, or the nurse's personal assessment of what's going on, and then the recommendations to do for the next step. That will improve those communication gaps, patient transfer, critical conversation, and telephone calls for you as the midwife to either the nurse, EMS, or the collaborating physician. So here are the different references. Go to the A1's fetal heart monitoring recommendations. You can go to a lot of different organizations have great protocols for emergency situations, SBAR communications. So take some time and do lots of research, because even though heart tones in a normal healthy setting can be rare of a concern, when they do happen, minutes matter. So please know your interventions, know the possible causes of what could make a heart rate low or high, and implement them accordingly.